It's my pleasure to welcome everyone to the next edition of a special edition of the Neonatal Hemodynamic Research Center and Pan American Hemodynamic Collaborative webinar. And our topic today is the evolution of artificial intelligence and echocardiography in imaging in neonates. We have a very interesting series of talks lined up for everyone, and we'll keep the panel discussion till the end. From the background of the session perspective, as I'm sure everybody is interested, that the artificial intelligence is actually quite rapidly reshaping our healthcare with the many applications coming forth, especially in neonatology also, where it can offer powerful tools for risk prediction, real-time monitoring, and sort of a data-driven precision care. It's no different, in fact, even it's more relevant to the field of neonatal echocardiography, where we feel it could potentially have a transformative role. In the neonatal echocardiography, as we all know, image acquisition and interpretation are very operator dependent. The lack of invasive monitoring tools and need for quick decision making and timely and precise cardiac assessments is a major clinical gap in a widespread adoption of echocardiography in neonatology. Subtle changes can be hard to detect. This is where we feel that AI-driven tools can really help and enhance our image quality, assist in automatic measurements, save operator time, improve reproducibility, and then perhaps early recognition of hemodynamic instability patterns. It is with this background and excitement that we have put together this particular session. So without taking too much of everybody's time, I'm going to hand over to my co-moderator, Stephania, who will sort of introduce the speakers and then sort of set the scene in motion, I guess.
Hi everyone, good afternoon. Thank you for joining us today. Our first speaker is Dr. Hamilton Baker. He is a dual board certified in pediatric and adult congenital heart disease, as well as fellowship trained in interventional cardiology. He has extensive experience in multi-institutional translational medical research in areas such as medical device testing, multi-scale modeling, and image guidance system development. His current focus is in applied AI in medicine, including the application of machine learning, deep learning, computer vision, and other related AI tools. He co-founded the Clemson MUSC AI Hub. So, Dr. Baker, you can start your presentation.
Great. Are you seeing my slides?
Yes, we can see them.
Excellent. Well, thank you for that introduction. It's kind of fun to see which one of the bios that I have floating around out there gets used for an introduction. It makes me sound a bit all over the place with my research, but I'm a pediatric cardiologist who about 8 to 10 years ago got very interested in artificial intelligence, and that led me to start the organization that was mentioned in the intro, the Clemson MUSC AI Hub, which I've had the pleasure of leading for the last 5-6 years or so. And it's really a research-driven institute between the two universities. And so that exposed me to a lot of different types of AI research throughout medicine, because it's not limited to just pediatrics, it's institution-wide. And then within my own area, I've always been very interested in imaging. And so it seemed the most reasonable place to apply AI in pediatric cardiology. And then some interest in work that I did in patent ductus arteriosus with a great group of folks has led me to be the one selected to give this talk. So what will we be talking about today? Just going to give a little brief overview of the historic development of echocardiography and its relationship with neonatology, talk over some quick AI fundamentals, but I won't get into too much because I think more and more people are developing really impressive amounts of knowledge about machine learning and AI throughout both cardiology, neonatology, and all across medicine. I'll talk a bit about some neonatal applications with some overlap in pediatric applications, touch on my own work with our group looking at PDA detection in the neonatal setting, and then some future directions. So neonatal echo is very interesting, and it's got its own challenges and certainly its own opportunities. I think you can find a lot of different percentage estimates for that one I placed on the screen. I put up a range because I found a range when I was searching across, just to really try and get a sense of the use of echo in the neonatal population. But whether or not that one is exactly correct, I think is less important than the fact that there's no denying that echocardiography plays an important role in neonatal care. Some of the interesting challenges, the transitional physiology, which I don't need to talk too much to this group about, but I think it gives such an incredible opportunity and challenge at the same time to try and apply AI techniques. Reliability is something that in neonatal echo has certainly improved over time, but still there's a good amount of room for improvement. Availability can be a challenge. Certainly it varies widely from different settings in the United States, across the world, within various countries, from rural to more large academic centers, significant variation availability of neonatal echo expertise. And the necessity is also both an opportunity and a challenge. I did my fellowship longer ago than I'd like to admit, but boy, we're getting close to 15 to 20 years ago. And I certainly was made aware of the necessity of neonatal echo, having to be the fellow that frequently on off hours and on weekends was responsible for performing those echoes and having to get the results back to the team in a timely fashion. So an incredibly interesting area. Evolution of echo, for those of you that were practicing back in the 80s, it was a bit of the Wild West of echo. It started off just as M mode and B mode, and throughout the decades has steadily improved with technology through the integration of Doppler techniques, and then around the 2000s, and even before, the huge digital transformation to DICOM, which made huge improvements in standardization in both recording and reporting. And then as time progressed, somewhere around the 2010s, probably even earlier, but we started to get even more sophisticated techniques like tissue Doppler, strain, 3D echo. Around this time, probably a little bit earlier, and there's people that are been publishing for much longer than this, and I know are experts in this area, but in my own looking into this, it seemed that the term hemodynamically significant PDA in relation to neonatal echocardiography really started to gain a lot of traction around this 2005 to 2010. Now, that's not to say that people weren't already doing it and publishing on it, but you can see by this little graphic that I have taken from PubMed that that's when the increase in publications really started to happen. And as it matured and then along with it, targeted neonatal echo began to mature. All of this started to come together, in around the 2015 time period. And you can see machine learning started to bubble up. How can we use this? That cross-roading with targeted neonatal echo. And then in the last 5 to 10 years, you've seen these things begin to coalesce, and many people begin to look at, what a great opportunity we have with all of these technologies coming together. So just some general concepts of AI and medical imaging. Around that 2015 mark, we saw more traditional machine learning methods. These were kind of handcrafted features, usually to accomplish a pretty specific task. They were often more rule-based algorithms with limited scalability. But as the field matured and AI matured, deep learning came onto the scene, which certainly had a profound effect on the capabilities of applying it to medical imaging. Some of the wonderful things about deep learning is its ability to recognize complex patterns. It certainly does require large data sets most of the time, but with other techniques you can, like transfer learning and other possibilities, you can still do a lot of work in smaller populations, and it has the ability to learn features somewhat automatically in either a semi-supervised or unsupervised approach. As we move forward and AI continues to progress, I think we're all very hopeful that we're going to move into more prescriptive systems that take the cutting edge AI technologies that we're seeing, where models are being built with multimodal inputs to really drive clinical decision support tools that can affect clinical outcomes in practice. So just quickly, a little bit more about deep learning. It does have a unique capability of detecting subtle patterns that can be beyond human perceptions. And this obviously is valuable in a lot of different settings, but I think it does have some key advantages in the setting of neonatal echo. When you combine that with the ability to begin to semi and fully automate part of the neonatal echo process, you have the opportunity to improve consistency in measurements among operators of varying skill, and that is very important in this particular area. In addition, it allows you to look at processes, temporal sequences, and in this area where you have a number of different clinical scenarios that are followed frequently temporally by echo, it provides a real opportunity. In addition, integrate multiple views in echo, but much more importantly, I think as we move into the true multimodal models, that's where we're going to see leaps and bounds, especially in this area. And so just to kind of lay out a process of a somewhat typical deep learning project that's, I would say at this point, not as complicated as some, but within the realm of echo, you're looking at collecting as many echo images as you can get for a particular subject and whatever you're looking at. There's often pre-processing, which can take a lot of different forms. In my own projects, that has been labeling for semi-supervised deep learning projects. And then most commonly, a convolutional neural network has been used for feature extraction, moving on to helping you classify and using pattern recognition to produce an output. And usually that output is a diagnosis or a measurement with some sort of probability around how sure the model is that it is correct. So just some example studies. Now, this is not specifically to the neonatal population, but I thought this was an important one to highlight, the EchoNet pediatric study. This was first large-scale pediatric AI ejection fraction model. What they did is take a model that had been built by adult cardiologists to look at ejection fraction and automatically calculate it in adults and fine-tune it to work in the pediatric setting. And Reddy et al. Did this fantastically. This was published back in 2023, which nowadays seems like actually a bit of a long time ago when you know the work was being done at least a year or two before that. But what this lets us know is that it is possible to take echo models that are built for adults in some situations and apply those in the pediatric and neonatal segment. Another very important study that I believe some of the authors of which are not only on this panel, but I'm sure in the audience and know the specifics of this study better than I. But I thought it very important to point out this publication, clearly very important in the neonatal population, but a tool that was created to predict the pharmacologic PDA closure in preterm infants. And this was published in the Journal of American Society Echo in 2025. Something else I'd like to note about this slide that I think is important to point out about the relationship between humans and AI. This slide was created by a large language model with only the abstract of this article. And I must say, and no, not even any formatting. And I must say, I am incredibly impressed at how this has come along in the last couple of years. And I think it highlights just how fast these models are moving. 2 years ago, if I would have tried to put something together like this, I probably would have spent more time monkeying around with the specific large language model and trying to get it to do what I wanted. But that digression aside, this was an extremely important publication. And in that, they took a convolutional neural network that was trained just using echocardiographic data. But then importantly, they created a multimodal convolutional neural network that looked at both perinatal data and echo, and then compared it to a logistics regression model as well as random forest and the image-only neural network. And they found that the multimodal network had higher accuracy. And I think this not only is important to this particular subject, but points out that, one, we don't need to always be fine-tuning adult models, that we can build excellent multimodal models in the pediatric and neonatal population. So getting more to the meat of the talk, why will AI transform targeted neonatal echo? I know that goes by a few different names, but I'm going to use TNE for its abbreviation in this talk. And I think because it is targeted, it makes it a great target for AI. A lot of the approaches are highly organized with well-defined goals about what is to be acquired during the study and what the desired information gained is. And while that is also part of traditional congenital heart disease echocardiography, I think that there's a particular opportunity here with targeted neonatal echo because of that fact. Also, data volume. NICUs produce a lot of studies, which is great for AI. Also, a lot of serial assessments on the same patients, which really builds to the richness of these data sets when you're looking at applying AI to echocardiography. It's time critical. And by that, what I mean is it's very important to get rapid interpretation, especially in unstable patients, in order to make sure that we're delivering timely, excellent care. Variability and reproducibility, those are pervasive in all types of echo, but I believe the opportunity in targeted neonatal echo for driving both of these down is almost better than any other area of pediatric and neonatal echo. Intra and interoperability, operator variability, it's a problem throughout all different types of echocardiographic measurements. But I think the more you can tighten that and decrease variability, especially in this field, the more it will help longer-term studies to identify the appropriate treatment pathways for a lot of these patients, at least the contribution that we can give from an echo standpoint to help in that. And then ultimately, hopefully drive down reproducibility to get optimal care pathways established. So I'd like to use in the rest of the time PDA as sort of a case study for why AI and targeted neonatal echo could come together so well. PDA, it's an important and well-suited case study. Has significant incidence. It's common. It's something that is treated, or wherever you fall on the treat, not treat, and how to manage patent ductus arteriosus. Its impact in this field is certainly evident. We have been producing research on this for decades, and still to this day are performing very strong multi-center trials to figure out exactly how to treat all of these different patients. And a lot of that, it's a continuous severity spectrum. It's a complex disorder, certainly difficult to put into binary buckets on how to treat. And so there still is some debate about treatment thresholds in this population. And so I took this part of a table from the guidelines and recommendations for targeted neonatal echo that was published in the Journal of the American Society of Echo. And what I'm highlighting here is something that I believe is true of targeted neonatal echo, is that it has specific goals. And that is valuable when you're trying to apply AI to a study to really help produce clinically useful information. And you can see these: confirm diagnosis, evaluate size, shunt direction, flow pattern, and evaluate the shunt magnitude. Now, there's certainly nuance there. Those are not necessarily simple goals, but they are specified, which can be very helpful in approaching these problems. So I tried to do that quite a while ago. I became very interested in just the echocardiographic portion of PDA. And along those lines, sat down and I made this graphic years ago, and I haven't changed it. And it almost now, it reminds me of sitting down and really poring over all of the different pain points that could come up in the PDA imaging workflow. And so depending upon what institution you're at, things can happen differently. But when a PDA is suspected and an echo is needed, It can go through a more traditional echo approach, like I see at my own institution, which is still more directly through the cardiology echo lab. But an order has to be sent. Somehow that is triggered in the echo lab. The sonographers will triage the studies. They have to travel to perform it. These days, that's usually transferred in near real time to the echo lab, but the echo reader must triage the echoes they need to read and then get to these and read and report on them. And then that gets retrieved by the team. In targeted neonatal echo, it cuts down that time in a lot of different ways and makes it more efficient, but there still is variability of availability, I would assume, depending upon the institution and the amount of institutions across the United States that have a hemodynamics program that's performing targeted neonatal echo. But again, this information needs to come back to the team about the echo. And usually there's some sort of hemodynamic significant grading that is returned to the team that has been very variable and certainly has evolved over time. And then the team takes that, synthesizes it with both echo and clinical lab, and then makes a treatment decision. So I know that was a bit long-winded, but going through all that, what I think is important is to point out those pain points where we can apply AI to improve care and help providers. And I think some of those are actually in the gathering of the echo information, not only guiding the study itself, and there's work being done on this in a lot of different areas of echocardiography, but how to take a sonographer that may not even be trained in pediatric cardiac sonography and help them get all of the important data that is purposeful in your study. In this case, it would be what's important for PDA, but you can see how that would be applied to a lot of different areas and indications in TNE. And gather that hemodynamic significance data accurately so that when it goes to the next step and it is to be read and integrated into the report, it's high quality. And then that next step is at the reading level. Even just confirming PDA presence, pointing out the important clips and so forth to a reader could be important. But if you could really get at semi-automating or automating hemodynamic significance grading or scaling or whatever way you want to term it, getting those done in a somewhat automated fashion would be very useful, especially if you could use those data and integrate them into ultimately sort of what I see as the holy grail of this process would be a high quality AI ML multimodal clinical decision support tool for the care of patients with patent ductus arteriosus in the neonatal setting. So with that background, I think if you sum it up, you could say, how can AI change PDA assessment and care? Well, I'm hopeful that we'll build models that can take all of the 2D and echo data and automate measurement acquisitions so that it's objective and consistent, automate that hemodynamic scoring once we can all agree upon what that is supposed to include, extract those features, integrate that with other physiologic and bedside parameters to do ultimately the type of pattern recognition that we are probably not even capable of doing, and provide those data to the care team through some sort of PDA clinical decision support tool, hopefully leading to more precise care in these patients. So I think that highlights the advantages that it could have for this use case in neonatal echo, where you wind up with predictive and even prescriptive clinical modeling, more consistent measurements regardless of operator skill, the ability to perform dynamic temporal monitoring whenever it is needed, and move towards precision neonatal PDA care. Another AI aside, I'm certainly an AI geek, but I took the information from the previous slide and fed it into a large language model to have it create a slide, and it came up with this. And I have to say I was pretty impressed. There are parts of it that are a little strange, but I think this again highlights just how fast models are moving in so many different directions and being able to accomplish an incredible amount of different tasks. If anybody wants this graphic, they can certainly have it. So in our group, to tackle this problem, our first step we felt was, well, can we train a model to identify PDA in preterm infants by echo? And so our first study was not huge. We started out in patients in our NICU that had PDA, and that was through the billing that we figured that out for the echocardiogram. And then we found controls that were billed as non-congenitals. We wound up with 165 studies in 66 patients, and those were the data that we used to train our model. Myself and Addie Gearhart, who's going to be joining us later, were the ones that labeled all of these clips. And we didn't label them as to whether or not we weren't making the diagnosis of PDA. We were simply selecting the clips that we felt were relevant in PDA diagnosis, and we defined those by particular views, including 2D and color compare. And after training, testing, and applying this, one very interesting thing that we found in building the model, I'm not going to go into all the specifics in this talk, but I'm happy to get more into it in the panel session. We found that reminder, this is PDA identification only, which we acknowledge is a simple task, and this is the first step in a process to get at full PDA evaluation. But as a first step, we found that only the color and color compare clips were necessary to build a model that had excellent performance in identifying PDA. And this graphic also points something out I believe is important when you're looking at how AI models perform. Often you look at how it did at clip level, but I don't think that draws a straight line to human performance. And that's why I felt it was important, and our group felt like it was important to look at study level performance, because you don't hand a neonatologist trained in target neonatal echocardiography or a cardiologist just one clip to decide whether or not a PDA is present. Now, there are certain clips, certainly you can show either of them and it'll obviously be a PDA, but that's not how it works. We get an entire study, and that's how we would judge a human's ability to identify PDA in a patient. And so I believe that's how we should look at an AI models. We looked at a little bit of interpretability and explainability. I'll quickly go through this. You see 4 frames here moving from left to right. The red flow is the PDA. The blue flow is flow through the pulmonary arteries. And so you can see at that part of the, on the axis below, the attention on the y-axis. In layman's terms, what simply that means is how interested the model was in that frame, and more accurately, I would say how much it was weighted in the model's decision as to whether or not a PDA was present. And you can see the attention levels are high when the red flow through the PDA is present. It falls as you don't see that red flow through the PDA. An important thing to point out that was in that slide, I moved through quickly due to time, is that our initial model, it only looked at left to right PDAs. We did not look at those that were right to left. And so after looking at our own internal testing, we did feel like it's important to move ahead with external validation. Children's Hospital of Orange County, Wyman Lay, and Anthony Chang and his group were kind enough to give us access to some of their echocardiograms to perform external validation. This hasn't yet been published, but we found good levels of external validation. And so in moving forward and moving towards our next step in this process and our next publication, we wanted to automate clip selection for model input and further validate it on other external centers. And so as part of automating clip selection, this is a fantastic slide put together by Addie Gearhart, who will be speaking later. All credit to her. I tried in a lot of different ways to come up with a graphic that was easy to make this process make sense, but I think this one does a great job. On the right side of the screen, you see PDA absent and PDA present, and that's what our initial our initial model was ultimately deciding. Is there a PDA present or absent? But now we wanted to design more of a pipeline to start to begin to automate this process. And what we did is our team trained a model, one, to select only the color and color compare clips from the study, and then a second model sequentially to find only those views that we had deemed were relevant and had originally been fed into our PDA detection model. And so taking out all of that manual work that Addie and I did in the first portion to find the right clips to feed into the model, we automated all of that. And what we found was that when we looked at the performance of the model in our own data, which is on the left at MUSC, there was very little, really no difference between the model's performance when it was fed those appropriately selected clips automatically by the models we built or manually by cardiologists. We found the same thing in our external validation data from Boston Children's. The performance was also quite good and in that process, and ultimately the model performed well. So we successfully have begun to automate this process and demonstrate that our model is working well with external validation. So where are we going to go from here? I hope that I've made a good case for the beginnings of the application of AI in PDA and targeted neonatal echocardiography. But I would hope that you can draw pretty clear lines to many of the other indications in TNE where this same process could be useful as we begin to build models that can accomplish the very well-stated goals of these echocardiographic studies. And by beginning to automate and semi-automate them, apply them to many different evaluations, and hopefully to democratize that capability so that we can have those studies performed on the patients when they need them and the teams get the information they need quickly. Another very important thing that will be coming in the future and is already here, honestly, I think if I could point out one slide to really show the importance of the future, it would be this slide, and that's foundation models in echocardiography and how they have already begun to automate tasks in adult echocardiography. This is a slide that describes a particular study and a model, a multimodal model that was built called EchoClip. It's what you call a vision language model. And so it isn't just trained on the echocardiographic data, it's also trained on the text descriptions. And really most of that is the echocardiographic report that is paired with that study. And in this study, they trained on obviously a lot of echocardiograms, over 1 million, that had paired text interpretations. But these foundation models are able to accomplish many different tasks that they were not specifically trained to do, which is impressive when you think about that ability. And similar to what we've seen in large language models, as they have had many of these emergent functions and properties. This one in particular was able to assess left ventricular ejection fraction. It could detect the presence of pacemakers and other devices in adult patients. And even more interestingly, it was able to identify the same patient pre and post intervention in either heart transplants or surgery. So it was able to identify that the echo was coming from the same patient, even though it was 2 different studies, pre and post intervention. I think this represents a huge paradigm shift in echocardiography and AI, and I hope that it will soon translate to neonatal echo, because I think there is a incredible opportunity if you're able to build a model like this. Granted, I understand we don't necessarily have access to 1 million echoes and matched reports, but in fine-tuning adult models and using and helping to do that by creating our own models, I hope that we can move this type of technology into the future of both neonatal and pediatric echocardiography. And so to sum up, some takeaways I hope that I've made clear are that AI will, I believe, improve the reproducibility and consistency of neonatal echo measurements. Deep learning is going to certainly enable pattern recognition that's well beyond human capabilities. I think that once we really get into this area, it's going to get very, very exciting. Neonatal hemodynamics is truly uniquely positioned for AI augmentation, and I hope that I've made that clear throughout this presentation. Recent research clearly demonstrates the feasibility of beginning to apply AI to TNE, and I think what we will see is this future evolution of moving from measurement to interpretation to true prediction in patient outcomes and assisting in therapy. And I also believe that as foundation vision models like the one that I was just speaking of, and its the technology that follows that will have the emergent capabilities to perform many different tasks, and that will really crack the world wide open for uses like echocardiography in targeted neonatal echo. With that, I think hopefully I was on time. Thank you for your attention, and I look forward to all of the other talks and a panel to come.
Thank you, Dr. Baker, for your very insightful work and presentation. Now, building up on that, we're going to introduce our research presentation speakers. First, we have Dr. Faith Su. She's a staff neonatologist at Mount Sinai Hospital, Toronto, assistant professor of pediatrics at the University of Toronto. Her area of academic interest includes the use of TNE in critically ill neonates and the long-term cardiopulmonary phenotypes of preterm-born children. She's going to talk about her work on development of automated RV assessment in pediatrics and neonates.
Thank you so much, Stephania, for this kind introduction. Let me just get my slides up to share. Are you able to see my slide okay?
Yes, but they're in presenter mode.
Ah. Let me try that again. How's that?
We can see them.
It worked well? Okay, awesome. So yes, thank you everybody for this lovely opportunity to discuss some of the work that we've been doing here in Toronto over the last couple of years. So what I'll be talking a little bit about today was kind of give you a bit of an insight into the process of how we developed they're developing an automated RVFAC assessment in peds as well as in neonates. I have no financial disclosures. Some of the work I will be presenting to you today will be coming from pre-published data. So FAC, that all of you guys know here, provides a good global estimation of RV function. It is already demonstrated a strong correlation with RV ejection fraction, MRI. Its feasibility is very well established in term as well as preterm babies, and we know from multiple studies it has association with various disease states. And we've also seen it as a marker of adverse outcomes in term babies with HIE. However, one of the limitations of RVFAC is the highly variable inter-rater reliability that can range from moderate to excellent, even between experienced assessors. So really the overarching aim of the work that we've been doing in the last couple of years has been to improve the quality of quantitative echo measures using automation. So far, the automated LV systolic function in adults and in peds, is what Hamilton's already showed, has been the most successful application of AI in echo. It's demonstrated good agreement with expert measurements, better reproducibility, reduced variability compared to humans, and also because these automated measures can be done in real time, actually has reduced the time needed to perform and analyze scans by about 70 to 80% without sacrificing any accuracy. But a lot of that focus has been on the left ventricle. When it came to the RV, there has been very few AI-based quantification models. And what we have done is that we took a slightly different approach to the existing LV models, where they have, as you've already seen before, they input either an image or a video clip, and what comes out as a result is a set of metrics like LVEF, or whether dysfunction or no dysfunction. But what we did was we used a segmentation-based model, which focuses on predicting the anatomical contours at the pixel level of the image. And we used 600 pediatric patients, 493 for training. And actually we used a variety of patients who had normal hearts, as well as about 40% that had tetralogy of Fallot and 10% that had pulmonary hypertension. And using this data, you can see here that we have been able to produce a model that has an excellent dye score. And what a dye score tells you is that when you put two images together, so the one that is annotated by the expert, and then another one that is produced by the model, which is this black and white image that you see, is what the overlap is. And dye score of 1 is a perfect overlap. And with our model, with a dye score of 0.93, we actually demonstrated a pretty excellent result. And when we looked at the mean absolute error for FAC prediction, this model actually was able to have a 5.91 error, which is actually pretty robust. So with this piece model that was developed during this time, we wanted to see how do we apply this to the neonatal population. We know in neonates is a limitation of a lot of the studies that we do, regardless of whether it's echo or not. Having small numbers is a limitation, and also in particular with echoes, being able to have very accurate delineation of the anatomical boundaries is also really important. So with this type of segmentation model that we've built, we've actually been able to mitigate some of these limitations. And in the neonatal population, when we apply this PEDS model, what you can see here on the left is a raw image that you recognize from the echo. The second column here is the annotated ground truth. So as the expert who is drawing the RV, this is what you expect it to be. But on the right, on the one next to it, the model generated image, you can see it's really off. That even though this model was trained on pediatrics, it really cannot be extrapolated very well for neonates. So what we did then was to use that pediatric model as a basis and train it with neonatal images. And just from a visual inspection standpoint, it's not perfect, but you can see that it has definitely improved after supplying it with some neonatal data. What we saw as well was that this pediatric model was performing pretty well on some neonatal scans, but not in others. So they see here on the right that had pretty good overlap, the orange being the PEDS model and the blue being the neonatal FAC predictions. Actually, they were overlapping pretty well, but for some neonatal images, the prediction was really off. And we use something called uncertainty score. So what the uncertainty score is an actual innate model's own self-evaluation of how confident it is that what it is producing is actually the RV area. And we use a cutoff of 0.2, where any score that's above 0.2 would suggest that this frame within the echo is not performing well. So after our initial retraining, we had 166 scans that were had a score that was above 0.2, and we did 2 rounds of fine-tuning using this uncertainty score threshold. And what we found that we had from 166 frames that were uncertain, this actually fell to 10. And what this proves is that, we have, despite having small numbers of frames or scans available in this population, we were able to still fine-tune a model to this population fairly well. So this is just how the model thinks it's doing, but how does it relate to what the FAC predictions are? And you can see here through the correlation model as well as the blind Altman plot that it's not great still. We are getting a R value of 0.69. It's not where we want it to be, certainly. And when we look at the blind Altman plot, you can see that the limits of agreement are quite wide. So with that in mind, we came up with a novel augmentation app. So this was sort of inspired by how we train our fellows. You know, they will do they will use EchoPack and, you know, draw out where they think the RV is. And you know, our feedback to them will be, you know, maybe this bit needs to go closer to the apex or that bit closer to the lateral wall. So we created this app where what you see here is this sort of red line is what the model predicts where the RV should be. And these individual dots are where we can actually drag and drop where we think that contour should be. So perhaps here you pull it down a little lower towards the apex. And as a result, you can actually, based on what the model's already done, tell the model how it can improve and provide it with an updated ground truth that is then going to be compared with what the model's already doing. And you can see here, following this step of augmentation compared to where we were before, our model is actually doing better when you compare the model derived prediction and the post hoc and the second iteration of ground truth that was provided based on the drag and drop app. And when you look at the bias and the limits of agreement, you can certainly see that this has dropped quite significantly, and it's much narrower in terms of the limits of agreement. So can I show you what we've done across the last couple of years? So what we started off with was a piece model. This was the initial annotation by an assessor with initial ground truth. And as you saw, you know, we could tell where the RV is, but actually the overlap between where the ground truth is and the model prediction was not perfect. And then following the fine-tuning and the augmentation app that we developed, this was the updated ground truth, so where we drag and drop from what we saw that the model predicted. And in comparison to that, you can see that actually the what we have augmented is closer to where the model prediction is, which perhaps reveals that there is some intra-rater variability as well, and how perhaps the model is influencing what we think is the ground truth. So it'd be really interesting to hear what the panel thinks and the discussion later on. But I just really wanted to use this time to just kind of highlight some of the things that we've done. What we've done is we've developed this PEDS model. We've tried to use it on the neonatal population, certainly not perfect, and ways that we can actually fine tune a PEDS model using lower patient numbers or lower scan numbers to get a model that is doing better and more robust. And also kind of interestingly, you know, we found, does the model training go both ways? Do we train the model and does the model train us? So kind of next steps from where we're going from here, we're bringing a second assessor, going through a similar process of the fine tuning of the model to really test this intra-rater variability and this whether the model trains us. And then from a much larger scale, we will be looking to develop a comprehensive automated T&E assessment looking at both right ventricle and left ventricle function, outputs, and some pulmonary hemodynamics as well. Of course, the work will not be possible without the collaboration with our team at SickKids, cardiology, as well as the computational medicine department. And these are the fantastic people that I've been working with. Thank you so much.
Thank you, Dr. Sue, for sharing your work. Next, we have Dr. Danielle Rios. She is a professor of pediatrics in the Division of Neonatology at the University of Iowa and director of the Neonatal Hemodynamics Clinical and Training Program. Her areas of academic focus are the hemodynamics of critically ill neonates and predictive analytics to improve outcomes of extremely low birth weight infants. And she's going to talk to us about machine learning for improving evaluation of diagnosis of hemodynamically significant PD.
Thanks, Stephania. So Hamilton talked a little bit about kind of, you know, what I want to do with this and talk about. So everybody, I think, is aware why it's not moving. Okay. Of the diagnosis of PDA, and we all want to make it a really simple diagnosis, but it just isn't. And so this is just a graphic here on the left where you can see that there's a lot of different cases of shunts that are greater than or equal to 1.5 millimeters. So that's what people in randomized control trials, et cetera, have said. That means it's hemodynamically significant. However, we know and we've shown that it could be significant, but it also might be supportive, or it might close on its own or have a low volume shunt. The graphic on the right just kind of shows that all of the PDAs that are more than 1.5 millimeters, some of them, again, are moderate to high volume shunt, and this was just a retrospective trial on patients that are getting a PDA screen at 24 hours. But there's also ones that are not, so not significant and don't need to actually be treated. And the other problem with this is that when you're actually measuring a PDA, like we all are going to measure it differently depending on how you actually get it, because it's not a perfectly linear structure. And that's going to be the biggest difference for our smallest babies. So we've moved to diagnosing the volume of the shunt based off of markers of volume status on echocardiography. And this is the Iowa PDA score that we have started to use. And so looking at that, we wanted to know, hey, all of these babies that we're saying don't need to be treated, are we doing something wrong for them? So we actually did look at babies who have a PDA for at least 2 weeks, but never met moderate or high volume shunt criteria, so only low PDA shunt burden, and showed that there was no difference between them and the babies that closed their PDAs in the first week of life. So that made us think, hey, we need some help finding out who needs to be treated, who doesn't. So this is a process graphic of, what we would like to get to. So you have a baby who's at risk of a PDA, and, if they have a UAC placed, then maybe we can have this PDA predictor that's running in the background that can tell us if the baby's at high risk or low risk of having a hemodynamically significant PDA. So we'll talk about this first step in that process graphic. So we wanted to compare all the vital sign data. We have continuous monitoring to see if we could predict a hemodynamically significant PDA. We did it retrospectively on babies from 2020 to 2023 that all got as PDA screen within the first 24 hours of life. They were all less than 27 weeks gestational age, so at higher risk of PDA. We did have some exclusion criteria, and we, like I said, collected the data from SickBay, which is the platform we have. And so we categorized them into 2 distinct groups. That was high volume PDA and no PDA or low volume shunt, because we wanted to make sure that we could see the difference physiologically between the two. So all of the PDA scores that were 3 to 8 were not included. And so we used the continuous vital sign monitoring with our PDA, with our UAC, and looked at the waveform and evaluated in 5-minute increments for the hour preceding the TN echo. And we used a Fourier transform to apply to that BP waveform that kind of looks at the shape of the wave, and really found that the harmonics, the amplitudes of the peaks or the harmonics, were important in our assessment of separating high volume shunts and no PDAs. And so we also looked at all the other predictor variables that we could, things that, were just vital signs or that people usually think are significant in PDAs, and then, only took the ones that were the highest performing in the final model, and those are the blue ones here on the right. And so we used logistic regression to classify those 5-minute windows and said whether they were a high volume shunt or a no/low volume. This, did the 5-fold cross validation with stratification so that we could train that model. And our results came up with a model that used 8 of the 14 predictors that I had shown previously with an AUC of 0.91. And then training the model 1,000 times with that holdout, we got an ROC curve that's here on the right side with an AUC of 0.88, which again is pretty well performing. And this is just, our clinical kind of demographics of the entire group in the first column, the babies that had no PDA or low volume shunt in the second column, and then those with the high volume shunt in the third column. And we didn't see any differences between any of the groups, except for mean airway pressure was slightly higher in those patients that had a high volume shunt. So how would we actually use this model? So as Hamilton was kind of talking about, this is taking us hopefully a step further in saying, is this something I need to treat? So this is a graphic of two separate patients who had a TN echo, and the TN echo is just at time 0. So it's prior to and after that TN echo that you're seeing here. And one of them had a high volume shunt and one of them had a low volume shunt. And so this predictor could tell us, hey, in the one that's the orange on the top, we should probably get an echo to diagnose PDA. And that's exactly what we could use this predictor metric for. So this is a patient who was a 26-week gestational age preterm who was on the jet, 21% FiO2 after surfactant, and their screening echo was done here at 24 hours. And you can see that prior to that, we would have been alerted a couple times at least that this patient was at high risk of having a hemodynamically significant PDA. And when we did the echo, the patient did in fact have that. So that would tell you, hey, get an echo. So then you order your echo. And now next step, like again, Hamilton was kind of talking about, is how do we get to the point where we can identify the echo clips that are important, do a deep learning method of analyzing those clips, and then spit out the IO-PDA score to tell me what I should actually do with this data. So again, our IO-PDA score with kind of the markers that we look at on the echo. And now we're moving more to that deep learning work. And so we want to see if we can improve those echo reads. So we went with what we thought to be the most difficult volume marker, which was LAAO, and tried to see if we could train a model in order to actually be able to look at the echo image and then measure it itself. And so we're getting close to getting the model to be able to kind of outline what it needs to actually trace so that it could measure it and spit out a number, a ratio for that. But it's a very slow process. And so we've had to kind of come together and actually recently talked with Hamilton and Addie about, should we continue this slow process of trying to break down the IO-PDA score and figure out how to do a model in order to measure each one of those. But the problem with that is not everybody has a hemodynamics program. And so not every echo lab is going to obtain the same markers. So do we pivot to a more generalizable deep learning method? That's something that, like Hamilton showed, it can pick out which images are important. And, without every single aspect of that IO-PDA score, perhaps tell you whether it's hemodynamically significant or not, and be more of the images that regular echo labs, like cardiology echo labs, are going to be obtaining in a regular echo anyways. Or do both, so that there's one pathway for hemodynamics programs and one pathway for cardiology programs. And eventually, hopefully, we can get both of those to kind of come together and start doing the same thing. And just always have to shout out to my hemodynamics program team that does a ton of work and gets us lots of data to do our research on. Thanks.
Thank you, Dr. Rios, for that very important contribution to this topic. Next, we have Dr. Josh Mayourian. He is a physician scientist in pediatric cardiology and founding director of the Congenital Heart Artificial Intelligence Lab at Boston Children's Hospital, Harvard Medical School. His lab's mission is to develop and implement advanced diagnostics tools to support pediatric and congenital care worldwide by leveraging AI and data science.
Awesome. Thank you for the introduction and the invitation to speak. Can you see my slides?
Yes, we can see them.
Okay, great. All right. On behalf of our team here at Boston Children's, I'm excited to share our work on automated echo detection of congenital heart disease using AI. Feel like I'll be preaching to the choir here, but conceptually, as we know, there are lots of large academic centers in the United States, but there are also dry deserts of healthcare where you don't have access to pediatricians, neonatologists, cardiologists. And the map here is showing in blue lower rates of mortality for infants, in red higher rates of mortality. And one common theme here is access to academic medical centers and access to care, essentially. And this really holds true not only in the United States, but globally. So the mission of our lab is, can we leverage AI to create diagnostic tools that democratize care and access to diagnostics and risk stratification to help triage patients and get them to sites earlier and better. So here's our lab mission statement: to advance pediatric and congenital cardiac care worldwide through developing and implementing AI-enabled diagnostics and predictive tools to transform data into actionable clinical insight. And today, what I'll be talking about specifically is AI-enabled echo for detection of congenital heart disease. Hamilton had brought up great points about foundation models, and here today I'll be sharing how we leverage a foundation model to detect a wide array of congenital heart disease lesions. So the framework we have is as follows. So on the left here, so as has been described, you can take one clip of a study or you can take a full study. And our goal was to create an infrastructure where we can take an entire echo study as your input to the model. And the output to the model is essentially whatever you want to train it on to predict whatever outcome you're interested in. In this case, again, we're focused on congenital heart disease detection. So what the model does is it takes the full input of a study, and for each individual study, it has a bunch of videos, and within those videos, it has all these different frames, and each frame is an image. So what this model does is it leverages an adult foundation model as a first step, where it takes each of those individual images and breaks up those images into and extract features. So you can describe those features essentially, if you will, as words. So you take all those words, and then we have a temporal transformer that takes each of the frames and contextualizes each of the words and puts them together almost like a sentence. So now you have a sentence based on the echo clip that you had taken. And you have each of these sentences for each of your given clips. So now I have all these clips with all these sentences, almost like a book that you're reading. And we added another layer to it, something called Echo Focus, where we have all the text, conceptually text or sentences from the Echo study. And Echo Focus has a transformer encoder or an attention layer where we trained the model to say, okay, you have all this information from the study. We want you to focus on what is most important to detect congenital heart disease. And the specific congenital heart disease that we looked at were 12 critical CHD lesions, a composite of critical CHD, as well as 8 non-critical CHD lesions, with PDA being one of them, and a composite of non-critical CHD. So to make this model, we took about 200,000 echoes between 2015 and 2025. And given our interest in identifying unrepaired congenital heart disease, we took the first echo per patient. So that puts us at about 60,000. And 60,000 is about our main cohort after excluding studies with a few clips. And then we created the model internally using about 80% of the patients and tested the model internally using 20% of the patients. And then importantly, we said, you know what, we get so many external referrals worldwide. Why don't we hold that as an external cohort? So you can see a map of all the echoes that we've received from worldwide. So this is 58 countries, 6 continents, to do external validation of our model, both within the United States and internationally. And with that, you can see all the patients that we have, the echoes we have, about 1 million echo videos internally and about 200,000 externally. You can see the range of ages here, and about 25% of the studies had non-critical CHD and about 5% had critical CHD internally, whereas externally, you can see that rate is much higher. So here you can see from our model internally in blue for all our critical CHD lesions, the model does quite well for detecting each individual lesion, so double outlet right ventricle, DTGA, Epstein, etc., single ventricles. But then once you look at the external model, so all our external studies, the model kind of fell apart. You can see the AUC went from 0.99 for HLHS down to 0.85 for tetralogy of flow, from 0.98 internally to 0.8 externally. So we thought that was interesting. And we said, okay, let's look at the composite outcome. And again, you see that same story. Internally in blue, when you're looking at all your studies, AUC of 0.94. Externally, when looking at all external studies, is 0.77. When looking only on external US studies, 0.74. When looking at only international external studies, 0.82. And then when we look only at infants, again, same story. AUC internal 0.93, and then external AUCs of 0.7. So we asked the question why. We really wanted to dig into why the model was falling apart. So we did some model explainability, and we asked the question, hey model, what views are you focusing on? And you can see for HLHS and tetralogy of flow, both internally in blue shade and externally in red shade, it's looking in the same view. So for example, looking at parasternal long, looking at subxiphoid for tetralogy of flow, parasternal long, as well as all these views listed here. So, okay, the models are looking in the same places. And then here, the take home point is that the model's looking in the same places. And when we asked an imager, look at those few views that the model is selecting as top 5 or top 10 videos, is this enough for you to tell if it's hypoplastic left heart or not? That imager said yes. For the most part, about 90% of the time, I can diagnose if it's HLHS or not. And about 90% of the time, I can tell you if it's tetralogy of flow. And this held true for both internal studies and external studies. So the take home is, okay, so externally, the model performance dropped, but the AI model is looking at the same views to make its diagnosis, and those views are important. So the next thing we did was ask, okay, what if we just do an unsupervised approach to understand what the internal studies look like in blue and what the external studies look like in orange, and just lay out what you think these studies look most similar and dissimilar. And you can see in blue, the internal studies compared to the ones in orange, they don't fully overlap with each other. And the meaning there is that the representation of these studies internally versus externally are not the same. So we then asked, okay, if you can't represent the studies as the same, maybe it's just that our internal studies don't represent the wide spectrum of machines that you have, echosonographers and acquirers. What if we just aggregate all the data together, both in the United States, so both Boston Children's and all the remaining US studies that we get as Ascent, and see, can we improve our external study? And indeed, we were able to show that our international studies had improved once we throw in not only Boston Children's, but also the remainder of US studies. So you can see overall performance for composite critical CHD now was 0.95 and 0.87 for all patients, and then looking at infants was 0.93 and 0.84. And then when going lesion by lesion, again, using this approach of training on that diverse cohort of Boston Children's plus the remainder of US studies that we had, really improved the external performance internationally. The last point I want to make is this framework that I described in the very beginning of that echo focus. I've only shown you results for detecting critical CHD, but we can use that same exact framework to say, rather than just looking at, can you predict critical CHD, we now can train models to predict any measurements that you're interested in. So in blue is internal testing, in orange is all the outside studies that we have. So you can see we can predict LVEF with the identity line being perfect and these numbers being the mean error, so the error being about 3% for LV ejection fraction. Here's for aortic valve diameter, and the list goes on for different measurements we can do using this infrastructure. So very thankful for our collaborative team of computer scientists, clinicians that make this work possible, and the funding as well. Thanks again for the opportunity to present.
Okay. Thank you so much, everyone, for their interesting talks and a lot of food for thought, I think. I think we're going to open it up for questions and answers from the audience. Please feel free to write your question in the Q&A. And I think everybody can, all the speakers and the panelists can switch on their cameras. Why don't I start by asking actually Hamilton. Hamilton, you've sort of seen these three people presenting their research sort of work. I was wondering if you have some feedback for them for their respective journey that is just starting and how they're going about it. I think it will be a good place given your experience and expertise in the field.
Well, I mean, I'm honored to try and give these folks advice. I think they're doing a great job. I think I'm very excited to see the research. I haven't come across any of it, and I try to stay. It's so hard to stay abreast in publications nowadays. But what I would say is I'm impressed at how far you've already gotten. Keep at it. But most importantly, and it looks like you've already started to do this too, is surround yourself with the right folks at your own institution, and take advantage of the fact that as pediatricians, most of the time we're pretty nice about collaborating, even cross institutions, and most of the things that hang us up are data use agreements, et cetera, rather than our own willingness to actually share those data with one another. And the more that you can try to get out of your own silo of what you're doing and join efforts with others, I think that's the path forward for us becoming as successful in the application of AI to echocardiography as we've seen on the adult side. More than ever, numbers have always plagued us in pediatrics and neonatology, but more than ever, we need to get together to use larger numbers of studies for fine-tuning of adult models and creation of our own. I mean, I would love to see the creation of a true pediatric neonatal foundation model. It's just so much harder in our area. So, I'd love to talk with each of them about their specific research, and if they have any questions for me, I'd love to answer it. But nothing that jumps out at me as far as other than that general advice I just gave.
Thank you so much, Hamilton. I think I'll use this moment to also introduce our panelist. We didn't get a chance to introduce her at the beginning. Addison Gearhart, she's an attending physician at Seattle Children's Hospital and actually has an expertise in multimodality imaging for pediatric heart disease. And her research, as it should be for this particular talk, is focused on the application of AI to imaging and EKG data to improve the diagnosis and outcomes in pediatric cardiology. With that said, Addison, following Hamilton's journal advice, do you have anything for these guys and what you just heard? Any interesting insights from what these guys are doing?
Can you hear me okay?
Yeah.
Thank you for the invitation to participate to start. I think I agree with Hamilton that the collaboration is key. I think we kind of see that with Josh's data, like the external validation, where recruiting more centers and having more people involved seems to, show where there's deficiencies in a foundation model, but then also bring opportunity when you train on that multi-center data to improve our results. My curiosity too is for Josh specifically, when you trained your model, your foundation model, how did you get the diagnosis for, was it 200,000 echoes you had in the beginning? Did you use like ICD codes or what were you using, or FHIR codes?
Yeah, great question, Addie. So just to clarify, in this case, we, just because it was step one, we haven't yet received, done true external validation from asking centers to retrieve all their echoes and then us shipping the model to them. In this case, what we did is we already within our hospital system and data center have access to 30, 50 plus centers of echoes. So that's what we leverage within our data center. I totally agree with you, though, that collaboration is key in order to pull this work off. To answer your question about the diagnostic codes, all of it was Filer code based. As you know, the Filer codes, they're within or adding those within Boston Children's. The imagers use it religiously to actually identify each of the congenital heart lesions. So we felt like, and Sunil had gone through to do an adjudication process to make sure that we trust the Filer codes for each of these diagnoses.
Super exciting, Josh. Really excited about your research. About everyone.
I think I have a question in the chat box. More of a generic, I guess, ethical question, which we all come sort of, it's in everybody's mind. What may be the risk that we can anticipate with the integration of AI in an acute care setting, such as neonatal hemodynamics oftentimes is in the NICU? And I guess on top of that, how do you mitigate those? Anyone?
I can take a stab at that.
Yeah.
As a lab, the mentality that we've taken or I've taken has been AI is a supportive tool and almost thinking of like Bayesian probabilities and likelihood ratios. Just like how a cardiologist might make use of a BNP or troponin to help them stratify if they think somebody's at higher risk of whether it's heart failure or myocarditis. I think that's where AI tools and the outputs that it generates will also go, like a lab value. And with that, the only way to put proper guardrails on it and how to implement it in pediatric cardiology and pediatrics especially where it's high stakes is to do multi-center external validation to make sure the models are calibrated. 2 is to prospectively study them as your patient populations evolve and demographics evolve, that the model works well. And then 3, to study how AI and humans interact with each other and how the human uses that information to either improve or worsen care. There are studies that are published that AI plus human is worse than AI alone and worse than human alone. So it's important to just do these studies and put guardrails on how we're using the information to actually make best use of AI.
Thanks, Josh. Before I take on Patrick's question for everyone, just to push it a little bit further, and I think that's a question in a lot of people's mind who are not into AI, basically consumers, put it that way, especially in our field as clinicians. And institutions, and I think perhaps both you, Josh, and Daniel and Hamilton, probably the best people to answer it here, and then Addison, I guess, if you guys already been working with institutions. When physicians miss something critical, they get sued. When AI miss something critical, so I think that I guess what I'm trying to say is there's a difference between screening tool which overdiagnose and then a second person or an actual human confirms it. That sort of makes the intuitive sense to a lot of clinicians that the sensitivity has to be 100%. Because if a clinician is looking at all echoes again to confirm nothing has been missed, then we haven't really saved much time here. Especially in a situation like you are working on, Josh, like you can't afford to miss a critical congenital heart disease. But the fact is, even cardiologists miss it sometimes because they're not always straightforward. But when a machine learning tool misses it, it becomes a much bigger deal than a human missing it. How do you get across to your colleagues? Do you compare with human performances in the past, and as the institution I was willing to take the legal responsibility of applying that in real life? That in our field, it's a bit of a problem. What you guys have any thoughts on that?
I can take a quick stab at that one and then have other folks chime in. when I get this question, I think it's very important to take each case separately with the underlying approach that Josh suggested. We've had to incorporate new technologies lots. We have to incorporate lots of different data a lot when we're making a decision. So the framework is there. Now, there's no denying that AI is a different technology than we have seen before, and that it does come with some specific especially medical legal situations that you were referring to. I mean, there are also cases, I don't believe I don't know if any of the other panelists might know, but there haven't been any judgments made, but there are cases where physicians are being sued for not using AI tools. And so it really depends on the specific tool you're discussing. I think you'd have a really hard time if I rolled out, I came to your NICU and tried to sell you a PDA clinical decision tool and told you that it did pretty well in my center. You guys would laugh me out of your hospital, right? You're going to want to see a lot of data to back that up before you, especially if you go against your clinical acumen and judgment that you would have used to say, treat a patient or do something like that. So I think relying on the fact that medicine has had to do similar things, and that's the way we're trained, to optimize trust and not to fall victim to automation bias. I think you go 10 years down the line, then you are worried about automation bias. If you have a tool that's been around for a long time and does develop our trust and we become very dependent upon, and then we just kind of stop checking it, that could be a dangerous situation. But I've found most physicians to be skeptical enough, even the ones that are AI savvy and interested like myself. I still wouldn't just rely on AI to make a decision. But I'd love to hear what other folks think about that.
Go on.
Yeah,
Anybody?
I think that.
Oh, that was not. I didn't do that. She did it to herself. Perhaps in the meantime, Addison, do you have something to add, and then Danielle?
Yeah, I like Josh's analogy of it almost being like a lab value that you clinically use as part of your repertoire. I think the component of will it make you more efficient? I like thinking of like a sonographer who's really experienced who comes to me and says, this patient has a door with normally related graded arteries. And it kind of puts my spidey sense out that it's probably true. Like they've drafted the report, but it's this legal. Like I really see my job when I have experienced sonographers working with me is like making sure they didn't make any mistakes, right? Like they did the draft the report, but it's really on me and my ability to get sued, but also my knowledge and what I've trained on to fine tune the details and what about this anatomy physiology is important for the report, and to make sure that nothing was missed and what they scanned and we didn't miss any key images. So if AI could even sort through the images to make my reading quicker or remove the noisy images that we like, because in pediatrics, the patient may fly off the table and it's like a waste of time looking at that image, and just give me pertinent clips. It could also change my workflow and be a useful tool that could increase efficiency, and be something I fact check. That's kind of how I think about it.
Sorry, Faith, you got frozen in between while you were talking.
Yeah, sorry. I think my browser gave up. So yeah, I think agree with what everyone has said. AI doesn't replace humans, at least not yet that we've seen. And it, our medical knowledge, acumen, bedside experience still comes in, as an adjunct tool, and AI comes as an adjunct tool to these experiences to help hopefully improve what we're doing and make things faster, and as we've already seen. So can people sue AI? They probably sue the person who made the decision based on what the AI information was giving them.
Yeah, and just quickly to add to that, our predictive tool is probably one of the ones that people would be most concerned about because it's going to be running in the background and telling you yes or no, like you should get an echo. But obviously, if it's telling you no, don't get an echo, but your kid is crashing or like just getting sicker and sicker, it doesn't mean like, well, I can't get an echo, right? Like it's just trying to guide you faster when it's showing that it thinks that it has a high risk PD or hemodynamically significant PDA. So we can't just say like, oh, but the tool didn't tell me to get an echo, I can't get an echo.
How do you anticipate that your project being incorporated like into the PDA guideline screen? Like, would it be part of the guideline, looking at that first, or you will continue to use your same guidelines and also the projector?
I'm assuming that's to me.
Yeah, sorry for you.
So honestly, I feel like the biggest utility of our predictor is going to be in other institutions, because I don't think I'm going to convince my team or just the Iowa people in general, even the neonatologists, not just the hemodynamics team, to just stop screening babies, and we'll just let this predictor tool tell us who to screen and who not to screen. So really, I think that the most benefit that it's going to have is to those that don't have the same resources that we do, who can't just say, hey, there's this baby I'm worried about, I want to get a hemodynamic screen. If there's some institutions have cardiology not even in the same hospital, right? So it would be best for them to be able to kind of delineate who really does need a screen, and then who we can maybe keep watching and making sure that there's not something else going on. So I don't think it would be something that we will probably implement it as kind of a validation, of course. That's actually a study that we're talking about at the moment, but I think an external validation and helping others is going to be the biggest bang for my buck.
There's a very interesting question in the chat. I think I'm going to bring in Patrick for this as well, as given his age, the father of neonatal hemodynamics, I would say. Maybe grandfather.
No, come on, the son, no grandfather.
And I think this is an important question, because we are dealing with a very niche population with a small numbers in each individual sites. And a small proportion of the total, even in pediatric, is a small proportion of the total healthcare needs. And the question becomes, is there enough high quality evidence existing that we can use to train a model to tell us what to do? To bringing into Danielle's point, yes, we can train in model what we do as clinicians in our center, but is that the standard of care that we have already established across, that other people will buy in before they buy the model, train on that? So is there enough evidence existing?
You're asking me, Amish, what do I think? Yeah.
Sure. Because our field is often driven by physiology and experience a lot, because again, we don't have large scale RCTs, and the ground truth itself is debatable. Like, for example, PDA treatment or not treatment is still not a ground truth. So I think that's the question people, like this one person is asking in chat, that is there enough evidence to train an AI model in neonatal hemodynamics?
Yeah, so I think there's enough evidence, okay, but I can just share with you the lessons we've learned growing from 2 hemodynamics faculty to 9 hemodynamics faculty. The variance between people and the variance in how people perform increases, okay? And I would then say, if you see that with an individual center, then the variance between centers, between echo machines, and so forth is going to create a lot of variability out there. And I think, step number 1 is how much variability is there? Because if there's so much variability in how people acquire images, how they interpret images, how they measure images, then that certainly speaks to the world of AI to perhaps enhance the consistency and actually measure how much inconsistency is there, out there. I think for sure the good news is that a lot of us in our world have been trained in a similar pathway. So I think that creates a good foundation to actually then look at that data set. But we like to think that we're very consistent, but we probably are not as consistent as we think, And, I don't know if Fitz saw my question in the chat. I was really interested to know, what did you learn about the times in which you did not get as much impact of AI? That to me is interesting. What are the things that may make it difficult for AI to not work?
I think that's a great question. I think what you touched upon, the variability, the integrated variability is still a big factor. That when we're testing the model, validating the model, we're validating it on mine and yours, and yours and mine may be very different. So the results that we get could very well be demonstrating that. And certainly in the PEAS model, we identified this. But I think what is perhaps a mitigation factor that at least what our team have been doing is that rather than sort of training the model in the way that has been done in the other LVEF models, where we kind of give an input and gives a value, we actually want the model to draw the actual contour of the, or not draw, but predict the contour of the ventricle itself, which actually can, first of all, reduce the numbers needed, because it's a much more information-rich model than just a picture. But because we're going to the level of a pixel-based predicting, but also hopefully, I think we touched on a little bit at the end that maybe as we're training the model is training us. So do we actually narrow that intra-rater variability, and we're going to demonstrate it with a second person? Do we also then, as we keep going further and further into this, we are able to reduce that variability between individuals too as we get there?
Thank you. It's a great session, guys. Really, really wonderful.
And we're coming to the end of it. It's 3:30 already. It was very, very interesting. And it's a story which is unfolding as all of you guys are leading it, and making me feel pretty out of place now in the world of hemodynamics. Thank you everyone for joining in, and I hope everybody learned something from it. And thank you to the panelists.